Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the events, happenings, and people at your community hospital. Today we're going to talk about diabetes, a condition we hear about frequently, probably more and more in our communities, and some of you may even be dealing with diabetes. And we've invited a very special person, Janet O'Grady, who is our diabetes specialist here at Southampton Hospital. And also, I know this program will be airing during November, which is National Diabetes Month, and that's why we've asked Janet to be with us. She's a registered dietitian and certified diabetes educator. She's on staff here at Southampton Hospital, and we'll be talking various topics about diabetes. So thank you, Janet, for being on the show today.
Thank you for having me. I'm happy to be here.
I'm glad you're here. And I always like to start off with a little bit of description. Tell me about yourself and your role as a diabetes educator and your background, how you kind of came to this, and your qualifications also.
Good, sure. Well, thank you for having me. I'm really happy to be here, and I'm really pleased that it does coincide with the Diabetes Month.
Right.
And we will be having a table at the hospital, an information table for Diabetes Month. We will be giving out literature and information that will be posted. Okay.
Where will that be? Up in the front of the hospital
No,
somewhere?
it will be outside the cafeteria.
Oh, that's probably an appropriate place for it.
It is
That's
actually,
good.
because we seem to have
good.
gotten more traffic.
Yeah, that's right. That's
at
right.
that place. However, I'm very fortunate to be here, and I'm fortunate to be a diabetes educator.
Okay.
I've been living in Southampton, or excuse me, Bridgehampton since we had many years, since '01,
Right.
and been summering here since the '70s.
Wow.
So it was a pleasure to finally come and retire.
Right.
But then I found I wasn't really kind of ready to retire.
A lot of people discover that.
No,
don't
I
they?
did.
They're
I
not
did
really
discover
ready.
that, and so continued, and I was fortunate enough to be positioned here as the diabetes educator at the hospital, which is really, I have such a wonderful patient clientele that I just enjoy serving them. It's a pleasure. It is.
That's great. So what is a diabetes educator? What did you do to become a diabetes educator?
Good question. Okay, my career really was in the VA. I am a registered dietitian.
Okay.
And when I relocated out here, I saw there was such a need for people with weight problems and diabetes.
Right.
So I continued my education and became a certified diabetes educator.
Okay.
And it was quite a grueling process. They were very demanding. That was the Diabetes Association.
Right.
And went through a number of courses and sat for another examination at a tender age.
Oh wow, very good.
And became a certified diabetes educator, where you focus strictly on the disease entity and the disease process and the management, treatment, and care of diabetes.
And we're going to talk about diabetes specifically, and I know that you're involved both here at the hospital and some of our medical practices as well, right?
This is where we, in '01, where I started at Meeting House Lane.
Okay.
At that time it was called Hampton Care, and then it went to South Fork Medical, and now it's Meeting House Lane.
Meeting House Lane.
That's right, across the street.
So you're available both in sort of out in the community and here at the hospital.
Yes, exactly. Right.
Wonderful. Very good. Well, let's talk a little bit now about diabetes and what exactly is diabetes? It's a term, I think it's one of those things we hear all the time. Everybody thinks they know what diabetes is, but let's just get this fact straight right up front. What is diabetes?
It's nice that you say everybody thinks they know, because my patients will tell me I have a little bit of sugar in my blood, all right? And the textbooks would tell me that it's a metabolic disorder, and where the body's function is not producing any or sufficient insulin, and as a result, you're having an elevation in the blood glucose. How I tell it my patients is I tell them that the food they're eating is really not providing them with the energy they need. Because it's not being metabolized because of the lack of the insulin. So we, go through that scenario.
So there's sugar in many of the foods that we eat, and insulin helps the sugar basically be digested or metabolized. And without enough insulin, essentially the sugar is then getting into the bloodstream.
That's right.
Is that simple?
Well, in 101, what's happening is they eat, and the food breaks down, the carbohydrates break down into glucose.
Right.
As soon as that happens, the insulin kicks in, wants to take that glucose out of the bloodstream and send it to the cells where it's needed.
Okay.
Wants to send it to the brain cells, the liver. I sound like I'm talking to my patients.
Right. No,
and the
that's
muscle
good.
cells send it to the cells where it's needed for energy.
Right.
However, eventually what's happening is the cells have become resistant.
Okay.
So it's not accepting the glucose. It's staying in the bloodstream.
Okay.
So they're really lacking in energy, and there's many comorbidities that can go on from an elevated glucose.
So it's interesting. In some ways, it's too much sugar, but it's not. The sugar's
right.
not getting where it needs
That's
to
right.
be. Okay.
Oh, you got it.
Interesting. Oh, great. Thank you. And I've heard the term, but what is prediabetes?
Prediabetes to this day is just about an epidemic.
Right.
We have a lot of people with prediabetes.
Okay.
Actually, right now, we have like 86 million Americans, really, with
86 million?
Yes,
Wow.
with prediabetes. But
Wow.
the interesting thing is, 9 out of 10 don't know it.
Really?
Yeah,
Wow.
right. So basically, prediabetes is a stage where there many times the doctors will say, after they have their blood work done, your sugar is a little elevated.
Okay.
But it's not that much.
Okay.
So that means it probably really depends on the number.
Right.
Like over 100 and up to 125, 26 is the cutoff point.
Okay.
That's prediabetes.
And that's a measure of sugar in the blood?
That's right. That's a
Okay.
glucose reading from the metabolic panel.
Okay.
So once it's over a specific number, then it's diabetes. But under that number, it's prediabetes.
Okay.
And a lot of people are walking around. And they have, as I said, there's a great, and this number is increasing on a regular basis. And they have something called prediabetes. Now, about 15 to 30% of the people with prediabetes, if they don't make adjustments in diet and lifestyle and get those numbers down, they will lead into diabetes.
They will?
Yes.
Okay. So if you've got prediabetes, it's not necessary that it's going to become diabetes. It's not like you're on a one-way highway that you can't get off of. Okay.
That's right. That's right. And the literature will tell us that it's chronic.
Right.
And it can be controlled.
Okay.
Now, if you're a new person, newly diagnosed with prediabetes, there's a very good chance we can get those numbers down. And I'm happy to report, I recently just had a patient with about 9 to 10% weight loss.
Okay.
And the A1C, or the numbers, the glucose, and everything came down. And her last blood work, the doctor wrote, cured of diabetes.
Wow.
And I looked at that and I said, that's cool.
That's very good. That's very
cool.
good.
So I was very pleased with that. Even though the literature said it's controllable, it's chronic controllable.
Okay.
But there we go.
So what causes diabetes?
Oh gosh. There are certain risk factors, unfortunately, and some of them are modifiable, and some of them are not. Some of them you can't change.
Right.
So the ones you can change would be certain ethnic groups,
Okay.
Native Americans, non-Hispanic blacks, and
Okay.
also Hispanics.
So
Asian
Native American, non-Hispanic,
blacks, yeah, and
Native-
also Hispanic,
and Hispanic.
right,
Okay.
also specific, specific Coast Americans.
Okay.
And especially like the Pima Indians, you've got like a 75%,
Really interesting.
diabetes. So those are non-modifiable, all right?
Okay.
Unfortunately, age creeps into it.
It does,
Another
okay.
non-modifiable.
Okay.
And also a family history. Some
Okay.
people do have a family history and some people don't. And some people with a family history will not present with diabetes. Other people without a family history will present with diabetes. So the non-modifiable ones, and then there's other factors. The sedentary lifestyle,
Okay.
the diet, the
Right.
fast food restaurants,
Right.
And the obesity.
Is it possible for someone who is not necessarily at risk with diabetes, but if their lifestyle's not so swift to develop it? Mm-hmm. Okay.
That's right. If they're overweight,
Right.
and let's say they have hypertension or elevated cholesterol, so there are other comorbidities that could come into this. But yes, somebody without the gene can have diabetes.
Can get it. Okay.
Yeah,
So genetic and lifestyle clearly together.
right.
It sounds like.
that's right.
Now, I've heard the term type 1 diabetes, type 2 diabetes, there's juvenile, what are all these terminologies?
Where are we all going here?
Yeah, what
Well,
do
they
mean?
pretty much, the American Diabetes Association has pretty much dropped the term juvenile diabetes.
Okay.
All right, they're using type 1 diabetes and type 2 diabetes.
Okay.
And there's also something called type 1.5, which I think we can let go, but I can talk about that a little bit. But okay, so for type 1 diabetes, for years it was found, in children or by the time they were 5 maybe, or before 30.
Okay.
And
That's why it was called juvenile originally?
That's right.
Okay.
That's right. But what happened was to be a destruction of the pancreatic cells, the beta cells, in the pancreas. There'd be a destruction of the beta cells, and they would develop type 1 diabetes.
Okay.
Because without the beta cells, they would not be producing insulin.
Okay.
It was a quick onset, and it was usually pretty devastating
Okay.
to the children and to the families.
Right.
All right, and there would be weight loss involved. They'd be spilling glucose in their urine and ketones.
Okay.
And that would be type 1.
Okay.
So that would be an autoimmune disease. It could be caused by a virus, and sometimes idiopathic
Does
features.
type 1 only develop in children, or is it?
No.
Okay.
That was, okay, you took me
Okay.
into type 1.5.
Okay.
We have seen type 1.5, they're calling it latent autoimmune disease of adults.
All right.
And what is happening here, you could have a type 1.5 because they could be my age, your age, they could be older, they could be adults. And they could have had they could have been diagnosed with type 2 diabetes for years. And then all of a sudden, the oral medication they're taking is no longer working.
Right.
And that reason it's not working is because the pancreas is shutting down and giving out less insulin.
Okay.
So they have to go on insulin.
Okay.
So even though they might have been diagnosed with type 2, now they're now they're giving them insulin.
Okay.
And they could be type 1.5. It's called latent autoimmune diabetes of adults.
Okay.
LADA.
Latent autoimmune diabetes of
So
adults.
we got to
All right.
that one. I didn't think we would.
That's right. And then
Right.
so type 2.
Okay, type 2. Okay, the risk factors,
Right.
again, the risk factors, the age,
Right.
the family history, but more so it's the diet
Okay.
and the lifestyle
Okay.
and the weight,
Right.
all right, and the comorbidities if they have hypertension or, elevated cholesterols. Am I making sense on that
You're
one?
making tremendous sense on it. And I guess one of the questions I have then is, so if it's later in life, you develop the lifestyle kind of issues, when can you start to make some of those changes to your lifestyle? I mean, is it ever too late?
No. Good question. It is never, ever too late.
Okay.
It is not too late. You can start making changes now. What I try to do is work with the patients to gear them into the thought that they can prevent this from going, because there are complications of diabetes.
Right. Okay.
And my goal is to educate them on the
Right.
complications, because I feel if you educate a person, they have the opportunity to change or not.
Right.
But you have to give them the information.
Right.
So once they're diagnosed, what we do is we go through their diet and lifestyle. And I have to tell you, the diet is one of the hardest things ever.
Oh, I know
to make
I know
changes.
myself, giving up
Oh,
certain foods or
yes,
trying to
it's
drop
very-
a little weight
right.
is very
And-
difficult.
And a lot of people can just go and all of a sudden be fine and say, you know what, I'm really ticked off today and I
Right.
need something sweet.
Yeah, it's
or like that old
that
cigarette.
comfort eating you
right,
do
exactly.
once in a while. Right.
So what I try to, no, it's never too late. What I
Right.
try to do is work with them with their diet
All right.
and lifestyle
Oh, great.
and make the changes. We have to start slow.
Right, yeah. And I'd like to talk to you a little bit about that, but a little bit more on diabetes. So you said a fair number of people have prediabetes, don't even know
Yeah.
about it. But are there symptoms to look out for? I mean, what would be the symptoms?
Great, good, very good, yes. Well, for type 1 diabetes, as I say, it's a quick onset and there is weight loss, there is fatigue. For type 2, and also there's extra third, but type 2 diabetes.
When you say quick
Onset for type 1.
For type 1,
Because-
how quick is quick? Is it?
Well, it could vary.
Right.
Basically, there could be what they call a honeymoon period, where
Right.
it goes over a course of 6 months.
Right. Oh, really?
Okay?
Wow.
Yeah. But that's maybe not so quick.
Yeah.
But with type 2 diabetes, they could have had a little elevation in the glucose all along.
Okay.
And then the number went to a specific point where it was no longer pre-diabetes.
Okay.
It is diabetes. So what would the signs be? For type 2, you'd probably be very, very thirsty.
Right.
You'd probably be going to the bathroom a lot.
Okay.
Increased thirst, increased urination, okay?
Right.
And you could have some other, comorbidities, some other issues with that.
Okay. And I've sometimes heard fatigue can be an issue
Yes,
too?
absolutely, yeah.
Suddenly,
They could be fatigue, or
Right.
they could have impaired vision,
Oh, really? Okay.
and they don't quite know, what this is all about.
Right.
All right. And if the glucose is high for long enough, they could have like very dry skin,
Okay.
or even poor wound healing.
Okay.
And I can even see people with were just diagnosed, they already have like peripheral neuropathies.
Oh, really? Okay. Interesting. So, what do you do then to manage that? I mean, what are the steps to manage once you've been? First of all, I guess, if you've got any of those symptoms, what should you do? You obviously probably want to go see a doctor, but what will the doctor do to?
Well, the doctor, on reflection of the blood work and the physical,
Okay.
they hopefully will send them to, a dietitian or a diabetes educator, or hopefully our program here at the hospital, which is
Okay.
really thriving and doing well.
Right.
So hopefully they will send them to a professional to, be counseled.
Okay.
And what we do is to manage it, I start with, where are we beginning? What is
Right.
your diet now? What is your lifestyle now? How are you monitoring? And are you seeing an eye doctor, a foot doctor? So there's a whole number of parameters, Bob, that I go through
Okay.
to check off for their management and their
Okay.
care.
And if I don't manage it, and I hear a lot of people say, "Oh, I have diabetes. I'm taking insulin," and it sounds almost cavalier that I take a little medication and it's over and done with. But I know that there was a time when diabetes was a death sentence before they
was.
really knew how to treat it.
That's right, before insulin.
So it's clearly a severe disease. But what are some of the symptoms, or what could happen if it's not treated?
Well, there are complications of both type 1, type 2, and the latent autoimmune. There are complications
Right.
of diabetes, and nobody gets away with them.
Okay.
They don't discriminate. It happens to everybody.
Right.
If the glucose is elevated over a period of time.
Right.
All right. There are the nerve endings in the hands and feet
Okay.
that can go dead, and they'll have peripheral neuropathy. We actually had a patient come into Southampton Hospital with a pebble in his shoe, and it was a couple of years ago. They had to cut his shoe off because his foot was so swollen, and he
Really?
didn't feel it.
Really? Wow.
Okay?
Because of
So-
the loss of the.
Yeah, so loss of nerve endings, a
Yeah.
loss of feeling. So there can be peripheral neuropathy.
Okay.
The elevation of the glucose can affect the kidneys,
Okay.
and because the kidneys are not excreting this, and there can be kidney damage. This is one of the first things we look for in the urine, if there's
I
any
was talking
protein.
at one point, we did a program with Dr. Hofford, our
Oh, yeah.
nephrologist, and he talked about diabetes being a major cause for kidney failure.
Yes, yes, because people don't, or when they have their blood workup done, they should also have like a microalbuminuria to see if they're spilling, protein,
Okay.
as well as glucose in the urine.
Okay.
So the kidney effect, and then the eyes can become affected.
Right.
The
Can you
retina
go?
is too
Can
much
you go
glucose.
blind from
There's
diabetes?
there's too much glucose, but basically with age, some people get macular degeneration.
Okay.
Now, it can be connected to diabetes, or could be just in addition to diabetes.
Age-related. Okay.
Yeah, it could be age-related, but yes, so we need, when I go through my list of follow-ups, it should be the eye doctor or the foot doctor
Okay.
as well as the
Okay.
complete blood count, blood workup.
And I've known that the issue of round wounds on the feet and
They
thing,
don't
that
heal.
sounds that, and is it's causing the wounds, or it's just, you say it's because they don't heal as well with the.
No, they're not healing as well.
Right.
But I've had a wound care nurse over here at the hospital, Jennifer McCormick, who I worked
Okay.
with, and who sent me patients and who I sent patients to them.
Right.
And for wound care, and I did have, we had some corroboration there for wound care. But no, the wounds don't heal. So those are some of the microvascular. Then you've got the heart. It can affect the heart, and it can affect the brain. We'll have a stroke.
Really? So something we absolutely need to take
Yeah,
seriously.
right. And all this could happen from elevated glucose over an extended period of time.
Okay. And I guess next question is, you've got a family history. I do, in fact. Both my parents had diabetes later in life. And something I've thought about, can I prevent it? And can you prevent diabetes? Like what steps would somebody like me with a little bit of family history, what should we take? So.
Well, hopefully you're having, updated blood work.
Right.
Complete metabolic panel. And they should also be doing something called like an A1C.
Okay.
That's in addition to the glucose test.
Okay.
To see where your numbers are and to follow through on that.
Okay.
And then the other thing I will focus a lot on is, of course, the diet and the exercise. But as I was saying earlier, when the food gets broken down, the carbohydrates get broken down into glucose, what I focus on really is something called like a glycemic index. We want more high fiber foods.
Okay.
So it doesn't get broken down immediately where it spikes the sugar.
Okay.
We want something like a more complex carbohydrate where it wouldn't spike the sugar as well. So I would probably say you should focus on fiber in your diet.
Right.
You should stay away probably from refined sugars, definitely, and any type of simple sugars, and also white products.
White products?
Yeah.
Any kind of white breads and things like that?
Yeah, because that's the highest glycemic
I
index.
love that bread too.
So the higher the glycemic index, the quicker it's going to break down to sugar.
Okay. Is there a way to find out what the glycemic index is?
Sure, there is.
Of
You can
things?
come to my classes.
Okay, great. I guess I'll have to
Well,
look.
there are books. It's called the GI index.
GI index?
Yes,
Okay.
glycemic index.
Glycemic index. I will check that out.
Right.
So in your opinion, is the incidence of diabetes increased?
Oh my gosh.
Yeah.
Enormously,
Right.
enormously. It's almost like 4 times the amount. I think we're getting 18 million new cases a year. 1.8 million.
1.8 million.
Excuse me. Yes,
Yeah.
new cases a year.
Wow.
Since 1980.
Really?
So that's where we get that big number.
Yeah. Oh boy. And that's linked to, what do you think that's linked to primarily, in just your opinion?
Diet, lifestyle, and also so many people today. How many people are not doing what I did as a kid? You know, I was out where my kids were out till 7 o'clock at night when it was dark, and I had to call them in or something.
Right.
You know, they're not.
Right.
The kids are sitting on the computer.
Yeah, we are a lot more sedentary.
The moms are
aren't we?
working.
So,
So it's a different. It's a different lifestyle.
Right. And kids are certainly, I know, getting them out to play pickup ball or something doesn't seem to happen. Video games seem to be much more prevalent among children.
And I have some patients who tell me that they did not have diabetes until they relocated to this country.
Really?
Oops.
Yeah.
Have you read that in the literature? Yes.
Yeah, I have seen that, stories of people coming from other places and suddenly adopting an American lifestyle and developing. So let's talk about your role and the role of the dietitian and the certified diabetes educator. Frequently in healthcare we think, oh, I've got an issue, I'm going to go to the doctor, doctor's going to give me a pill. And it's not so easy, as we know, for many conditions. And that's where people like you become very important. So talk about your role then, what you'll do. And can somebody just go to see you, or do they need to be referred by a doctor?
No.
Okay.
Basically, well, that was our CQI last year, where we did ask for referrals from the doctor or the American Diabetes Association. But we'll talk about my program afterwards. But really, my role is to go over certain parameters.
Right.
And I have guidelines from the American Diabetes Association.
Right. Okay.
As we are a certified program.
Right.
And I have to, check off. Patient has to be checked off for all of these particular. Are they seeing, the eye doctor? Are they seeing the foot doctor?
Right.
Then what I would do initially is I would go through their diet, their weight, their lifestyle, and make small incremental changes.
Okay.
And have them come back, each time with a small change.
Sounds like you're developing almost that complete story or picture of the patient.
That's right. It's not just one, right? It's not just the diet, right? It's the whole picture. However, if they can't come here, see a dietitian.
Right.
Or some of the doctors, some of the endocrinologist offices have, like they have a nurse practitioner who will give them guidelines. But I have a lot of good literature from the American Diabetes Association, which I'm very free with. And we set each person on an individual program, Bob, that they start on a particular program.
Tailored to their
That's
specific
right.
needs.
Exactly.
Because in some cases, it
No.
may not just be about
No.
losing weight, it's
No,
also
it's not.
getting a little, becoming
And
a
it's
little more
also
active.
ethnic choices.
Right, okay. Ethnic choices, really?
Yeah,
Okay. Foods
right.
that match?
That's right.
Okay.
Right. Oh, I'm only going to eat the rice and beans. Well, can we try brown rice?
Right, right, exactly, a little different.
And then I talk to them about, the beans, which is a good choice.
Okay, interesting.
Mm-hmm.
So it sounds like diet really clearly plays a major role, and there's so much talk about diet and what we eat, and frankly, some of it can be confusing, but let's talk about that. That diet clearly has a role in diabetes. And,
Well, I try to tell my people, and I do, that there really is no diabetes diet.
No diabetes diet, no.
In fact, they say, well, I eat diet cookies. I don't want you to. No, I want you to throw them away. There
Okay.
really is no diabetes diet. Basically, what I focus on really are healthy food choices.
Okay.
If you can do a plant-based diet, that's grand.
Okay.
But if but I don't change them. I
Right.
don't put anybody on vegetarian if they're not already a
Right.
vegetarian.
Okay.
But we look at our healthy food choices. So
Okay.
tell me what you are eating, and this is what I'm going to make an adjustment with.
Okay. And
So if you are eating rice, let's try, some brown rice.
try brown rice,
Okay. And if you are doing your chicken, we're not going to have fried chicken. We're going to
Okay.
take that skin off.
Okay.
So there is really no diabetes diet, but I do avoid simple carbohydrates as much as we can.
Okay. So that would be certainly sodas, anything with sugar in it. Breads, are there any breads that
Oh,
are okay to eat?
absolutely.
Because I love breads.
Absolutely, whole grains, a good
Okay.
choice,
Okay.
because you have a lot of minerals in there. You've got a
Okay.
lot of minerals. You've got magnesium. You've got because they're added to.
Okay.
So we have a lot of good stuff in the whole grains. Yes, we do whole grains. We don't do white flours.
What about protein versus carbohydrates? Is there a difference there, or what's?
Yeah, sure. But however, what I like to have my patients really do is have both
Okay.
with each meal, with their meals.
Right.
They do need their protein. They do need so many ounces depending on the weight and the height of the patient. They do need protein with each meal,
Right.
in addition to a complex carbohydrate.
And give me an example of a complex carbohydrate.
Okay,
right.
your whole grain
Okay.
bread.
Okay.
Right? Okay, there you go with that one, right? Mhm.
So-
Or even your beans. Beans are a starch as well, but it's also a protein.
So beans would be okay. then.
Beans would be good.
What about fruit?
Okay, glad. Now, fruit is really a simple sugar, but it's fructose
Okay.
as compared to a glucose. It's a soluble fiber, but it breaks down slower.
It does. Okay.
However, when I have a patient have fruit, I suggest a little bit of protein and or fat with it.
Okay.
Why? Because sometimes if a person were to have a very ripe banana, I tell them not to have ripe bananas, not a ripe fruit, because that will break down quicker to sugar.
Really?
There's little tricks to everything.
Yeah.
So when they have the fruit,
Green
yes.
bananas just don't taste as good, though. So, yeah.
Oh, no, I
Yeah.
don't want, no, we're not going to
Yeah.
do green.
Yeah.
But, we're not going to do green. But however, yes, fruit, they can certainly have fruit, but it should be with another food.
Okay.
Or if they have it for a snack, they could have an ounce of cheese with it.
Okay. So cheese would be okay.
Yeah. Or even, if they were going to have something, well, maybe not fruit, but if they were having like some non-starchy vegetable, they could have a little bit of hummus with it.
Okay. Any fruits other than ripeness? Are there any fruits that are more challenging?
Yeah,
or-
I have my patients avoid juices.
Okay.
All right, and if they were really to have a juice, they have to dilute it with water, and
Oh.
it can't be orange juice.
Yeah, I know a lot of the juices that they sell. If you look at them, there's a lot of sugar in that stuff. So. Yeah.
Well, when we teach them to read food labels, and when they're reading a food label, I have them look at the carbohydrates. Really,
Okay.
to read the amount of carbohydrates, because they look at the amount of sugar and say, "Oh, there's only 5 grams of sugar, but there's 25 grams of carbohydrates."
Wow.
So we want to focus on the carbohydrates.
Okay. And vegetables generally?
Yeah, great choice. Non-starchy vegetables.
Okay.
Half the plate should be with either, a vegetable or a grain.
Okay.
Okay. This is what, we're looking for, the vegetables and the fruits
Okay.
for that. The non-starchy vegetables. Your starchy vegetables, if you were to have a potato, I would suggest a sweet potato.
Oh, really? Even though it sounds
Yeah.
it's sweet, but
Why? Because it has vitamin A and fiber.
Okay.
And fiber.
And fiber clearly sounds like the best thing for us.
Mm-hmm.
What diabetes superfoods? What's that?
Oh, it depends who you ask.
Right.
So the American Diabetes Association likes They like beans because they're a protein source without the saturated fat. They like berries because it's an antioxidant, with all your berried berries. And you can have a good amount of berries. Now, let's say you were to have cereal.
So blueberries,
in the morning.
strawberries?
Yes, you could put some in your cereal because you're going to have some milk there as a protein source with it. So they also like citrus.
Okay.
Now, again, citrus is a soluble fiber in vitamin C. Dark green leafy vegetables. Everybody will tell you about the dark green leafy vegetables, even Andrew
Hearing
Weil.
a lot about kale these days.
Yes, kale. Well, spinach. You can get a package of spinach and have some good sources of spinach right there. Okay, and then you want to go on to low-fat dairy.
Right.
Vitamin D, and then nuts, a good source again of protein and magnesium with your nuts.
Okay.
All right, and then you can go on to tomatoes. The American Diabetes Association likes tomatoes because they say it also has vitamin C and iron and magnesium.
Okay.
And then you're going to go on to whole grains. So there are a variety. Now, if you ask Andrew Weil, he would give you addition or subtraction of that group.
Okay, interesting. Well, that's why it sounds like having a diabetes educator is very helpful, just to learn what you eat and like and don't like. I have two last questions very quickly. Dessert?
Oh, nothing's wrong with dessert.
Okay.
Okay? We can go for dessert. Yes, you can have dessert. We have to talk about moderation.
Okay.
All right? And you have to really look and what time you're now. If you are on insulin, if you are going to be using a pen at night or something, it has to be in conjunction with the rest of your meal plan.
Okay.
So you can have X amount of calories or X amount of carbohydrates for your dessert, but it has to be in conjunction with your meal plan.
Alcohol, a glass of wine
Okay.
or so?
Yeah. I would say a gentleman can have up to 2 drinks a few times a week with food, and a lady one cocktail.
Okay. So all things in moderation.
With
that
food.
That old advice sounds like.
With
food, right?
Yeah,
okay.
right, with food.
Great. And unfortunately, we're out of time, but I would like to just point out that anyone in the community that wants to come to the hospital and talk to you, that you are available. How do they access you?
Okay. Basically, I see my patients through the Wellness Center.
Okay.
And we make appointments through the Wellness Center, and that's where I see them.
Okay.
And we take, of course, Medicare covers diabetes across the board, and most of the healthcare plans also cover for diabetes education. And the Wellness Center has many other programs to offer.
Right.
So if my patients are here, I will recommend them to go to the fitness center and for exercise.
Right. Or some of those other nutritional classes and things.
Right. We have a lot in the Wellness Center, but yes, that's where they would contact the Wellness Center.
Well, that's wonderful.
I
really can't thank you enough, Janet,
gosh.
and I hope people do continue. I know
so
you're
too.
very busy, but we always eager to see
Thank you.
see anyone who needs your help. And in closing, I just would like to say thank you to Janet, and thank you all for watching us today.
Thank you for being here.
If anyone would like to have a consultation with Janet, you're welcome to attend our free monthly class, Living with Diabetes, that Janet offers. It takes place in Southampton Hospital's Ed and Phyllis Davis Wellness Institute. You can please call 631-726-8800. That's it for this month. I'd like to thank our friends at CTV for producing this program and airing it in Southampton, and our friends at LTV for showing it in our East Hampton communities. All of you for watching. If you have any questions or would like to learn more about the programs and services at Southampton Hospital, if you need help navigating our healthcare system here on the East End, please feel free to call my office at 631-726-8555. Thank you, everyone, and good health.